Okay, great. So let us get started. Apologize for the technical delays going on. Good evening and welcome back to the Lipid panel. My name is Dr. Ann Carol Goldberg. I'm the co-director of programming of the Lipid panel, working alongside Dr. Dan Sofer and Brittany Thompson. The Lipid panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, Lipid Clinic Conference is a great way to debrief after a busy clinic, to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies, and to come together with colleagues. For the rest of us who feel like we are on lipid islands, conferences like this remind us that you are not alone. If you have cases that you want to be presented at future lipid conferences, please email Brittany Thompson at bthompson@lipid.org with your suggestions. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, and try to get to as many important clinical topics every lipid specialist needs to know. This series is meant to be a monthly coming together of rising stars, that is the lipid scholars and early career lipid specialists and more experienced colleagues. Look for our schedule posting for the final Tuesday of every month. This evening, I'm joined by a superb panel. Dr. Chad Morreale will be presenting the case. He is a cardiology fellow at Temple University Hospital in Philadelphia and an FNLA Lipid Scholars Program participant. Dr. Katherine Cheeley will moderate the program. Our panelists include Dr. Savitha Subramanian, Dr. Dan Sofer, and Ms. Lauren Williams. Dr. Subramanian is an associate professor of medicine at the University of Washington in the Division of Metabolism, Endocrinology, and Nutrition. In addition to clinical responsibilities, she teaches at the university and participates in content development for the Endocrine Society, the American Board of Internal Medicine, and the National Lipid Association. She is also a recipient of the 2022 UW Cares Award for exemplary patient care. Lauren Williams is a clinical dietitian too at Baylor Scott and White McLean Children's Hospital in Temple, Texas. She is an at-large board member of the Southwest Lipid Association and is on the FNLA's Pediatric Work Group, or PEDAL. Our other panelist is Dr. Dan Sofer, who's a clinical associate professor of medicine at the University of Pennsylvania. He's involved in many aspects of the FNLA, including being co-director of the lipid panel and the Foundations of Clinical Lipidology course. He is also the president-elect of the FNLA. In a minute, I will turn over the direction of this program to our moderator, Dr. Katherine Cheeley. She's a clinical pharmacist and executive director of ambulatory pharmacy services at Grady Health System in Atlanta, Georgia. Her clinical areas of interest include lipidology and medication adherence. Welcome all to the lipid panel. Dr. Cheeley, it's all yours.
Awesome. Thank you so much. And thanks, guys, for joining us on literally the last day of January. So it just so happens that it was the last Tuesday. I'm really excited for us to dive into this case. I think it's going to be a fun one because I know the ending, but you don't. But Dr. Morreale, take it away.
All right, thank you very much. Let me get my slides ready. Okay, so we have a 12-year-old female who presented to our pediatric hospital for abdominal pain, nausea, non-bloody, non-bilious emesis for 2 days. Her pain was exacerbated by PO intake, both food and drink, and she denied fever, chills, diarrhea, and constipation. Of note, she had 2 similar episodes in the past over the last 3 months, both lasting 1 to 2 days and were self-limiting. In her last menstrual period, it was noted to be 3 weeks earlier. Her flow was normal and regular. And in her review of systems, it was positive for easy fatigability, subjective weight loss, hair shedding, and hot flashes. In her medical history, she was born full term via C-section. She had no past medical history or past surgical history. She had no home meds at home. She had no allergies, and her social history was grossly unremarkable for a sixth grader. No tobacco use, alcohol, drugs. She enjoyed dance, swimming, running like any kid. Her family history was noted for a mother with diet-controlled hyperlipidemia and hypothyroidism, and her father had non-insulin dependent type 2 diabetes. Her parents were also reported to be third cousins. On her physical exam, she was alert and oriented ×4, well-nourished, no apparent distress. Overall, her exam was unremarkable except for the abdominal exam, which was soft, diffusely tender to palpation without guarding or rebound. Her abdomen was non-distended, had active bowel sounds, and no hepatomegaly. Because this is the lipid panel, I'll also just point out that she had no arcus senilis and no tendon xanthomas either. Looking at her growth curves, for her height, she was between the 25th and 50th percentile, starting at age 12. For weight, she ranged between the 50th and 75th percentile. And for BMI, she ranged right around the 75th percentile. On initial workup, she had a slight elevation in her blood glucose of 131. Her chloride level was 19. Her amylase and lipase were noted to be markedly elevated, lipase of nearly 3,000 and an amylase level of around 300. Her A1C was 5.5%. Her urinalysis and TSH were unremarkable. Her lipid panel was noted to have a triglyceride level of 4,700. Her total cholesterol was 290. Her HDL cholesterol was 9, and her non-HDL cholesterol was 281. And as we would have expected, her alcohol and her urine drug screen were unremarkable. At this time,
yeah, can we stop right here and you kind of take us through when did you get the consult, kind of what your initial thoughts were on this child?
Sure. So full disclosure, I'm not a pediatrician. So I'm normally used to seeing adults with pancreatitis. But we initially got consulted on day 2 of her hospital admission. She, inconsistent with her abdominal exam and her lab markers, this fit the picture of acute pancreatitis, and with her triglyceride level markedly elevated, notably over 1,000, hers was 4,000. This is pretty much clinching the diagnosis of hypertriglyceride-induced acute pancreatitis. So through my mind at this point, I'm thinking, well, in a 12-year-old girl, what would cause her triglyceride levels to be so dramatically elevated? And in an adult, the first thing we usually think of is someone that may have been binging on alcohol. Of course, that's not the case here. So it's a bit unusual for a 12-year-old to have such a markedly elevated triglyceride level.
Yeah, Dr. Soffer, Dr. Subramanian, how would you guys, if you're the attending, how would you kind of take them through the process?
So when I see someone like, again, as Chad said, I'm also an adult endocrinologist. I don't see too many kids, but in this case, Chad, do you know if this was the first time she presented? Was this her initial presentation ever? That would be my first question to you. And then secondly, had she had any issues when she was younger with growth, missing school, unexplained abdominal pain, any history like that that maybe you elicited, or maybe you don't know that? Either answer is okay.
So to my knowledge, she didn't have any unexplained missing school or recurrent abdominal pain, other than the the 2 episodes 3 months prior to her presentation, where she had a similar type of diffuse abdominal pain that was exacerbated by PO intake. But at that time, it was self-limited to 1 to 2 days, and the family chalked it up to more so gastroenteritis, and she improved on her own and did not seek medical care. So this is the first presentation to a medical facility for this symptomatology.
Okay, thank you. And one other point I wanted to make. So you mentioned she didn't have tendon xanthomas, but in someone with marked hypertriglyceridemia like this girl, you would see eruptive xanthomas. So these are like yellow papular eruptions in pressure points like the elbows, knees, buttocks, wherever there's pressure. Was there anything like that that was reported to you?
No,
Or did
there
you
was
notice
not.
it? Okay, so she didn't have eruptive xanthomas. Okay, thank you.
No.
And I'm going to jump in and ask a question. At what point in kind of the course would you expect to see those? Do you see them in the acute time when the triglycerides are 4,000? Do you see them after it's been 4,000 for a year? When do you kind of expect to see that eruptive process happening?
Dan, did you want to take that, or you want me to answer it?
I'm not sure it's an answerable question exactly, because we don't usually know the time course for the development of hypertriglyceridemia. So most of our patients don't have lipid profiles done on a regular basis and then have it elevate and know. But it's not unusual to see it when they're presenting with their pancreatitis, but they could easily have this when they're walking around as an outpatient without any pancreatitis, eruptive xanthomas.
Yeah,
I wanted to add about the physical exam, Chad. I know we're putting you in a tough spot because you may not have even been in the ER when she came in, but there's a couple things that when someone like this comes in, you're in maybe the ER is not the best place to do it, but like in the office building where I see patients, I'm sure I am the only one who uses those fancy fundoscopes that are hanging on the wall, and the bulb is working just fine. So these patients, I love to turn out the lights, get their pupils as dilated as possible and get a good fundoscopic exam, get a chance to actually take a look at their arterioles to see if they have lipemia retinalis. And that's something I would always look for. Similarly, when whoever's drawing the blood can set aside a little tube for you, and while you're seeing the patient, getting the history, letting it sit there, the blood does not look normal in these patients, and it's a good chance to actually look at the lipemic serum as well. And always encourage that both those things to happen.
Someone else asked a question. What about lipemia retinalis? Did you notice that?
That's what I was just saying. Is looking to do a fundoscopic.
Yeah, no, I mean in this patient, did you guys look at that?
Yeah, admittedly, a fundoscopic exam was not performed at the time. And I'm not sure that I'm well enough trained to detect lipemia retinalis personally. I guess I haven't looked at enough retinas to really pick that up. But it's certainly something to review, before going to see a patient. Do a quick Google search. If you already know that their triglycerides are elevated, it's definitely helpful to do a quick Google search while you're walking to the room and look up the photo, and then you're a bit primed to pick up that physical exam finding.
Yeah. To Chad's defense, I want to say Dan is the master lipidologist. I can't pick up lipemia retinalis, so I pass on the fundus exam, but it's a good point. I do want to mention something, and as an extension to what Dan said about the lipemic serum. one thing sometimes, ERs don't think of pancreatitis. So, but the lab will, but they always draw labs, and it almost never has a lipid panel, but it has, it's comprehensive and everything else. And they will mention lipemic plasma or lipemic serum. And so if you look at that, so that's a clue right there. And so, you can have a lipid panel added on right away. The point about the eruptive xanthomas, I agree with what Dan said. But in some patients, the adults who have had recurrent pancreatitis, when they start to get these eruptions, they know that there's impending pancreatitis coming. So it's kind of like a pre-pancreatitis phase. And so then they realize, oh, their triglycerides are super high. And the savvy folks will start cutting their food intake down. But yeah, as Dan said, there's really no cutoff to know when those things happen.
There's a couple of lab abnormalities here that are also, I think, kind of interesting. One normal test result that's typically abnormal is the sodium concentration. So it's pretty common for someone coming in with hyperchylomicronemia and with or without pancreatitis to have what's known as pseudo-hyponatremia. So their sodium concentration is probably normal. And it's possible that the laboratory saw that this was lipemic and was able to really test for it and tease out the pseudo-hyponatremia. Maybe that's what's reported here. But I know our lab isn't quite so savvy, and oftentimes you get back, sodium concentrations 115 or 120, and everybody sort of freaks out about the sodium concentration.
Okay. So we'll continue on with the case. So now that we have kind of confirmed the diagnosis of triglyceride-induced pancreatitis, we'll start with the inpatient management of acute pancreatitis. So the first thing that we did was we made her NPO and started her on IV fluids. There's actually more traditionally, what was done was giving patients massive quantities of IV fluids because acute pancreatitis was thought to be a kind of sepsis type of pathologic process without an infection. So in the past, people were flooded with fluids. And I think nowadays we've moved to a more conservative or less liberal approach to IV hydration. This is kind of coming out of some of the critical care literature, using 10 milliliters per kilogram bolus followed by 1.5 milliliters per kilogram per hour. On top of that, we started pain medications.
Sorry, Chad, can I just ask, is that for all acute care, or are you talking about specifically for acute pancreatitis, that IV fluid strategy?
This is specifically for acute pancreatitis.
Sorry, thanks.
For pain control, we started her on Tylenol and Dilaudid pushes, which maybe Dr. Cheeley can chime in and give us her opinion on whether she thinks that morphine is something that's useful in acute pancreatitis with its theoretical action of constricting the sphincter of Oddi. And then there's other considerations as well for treatment of inpatient pancreatitis using insulin drips, heparin drips, or plasma exchange. For this particular patient, we did not use insulin or heparin drips, and we did not pursue, or I should say the pediatricians did not pursue plasma exchange.
I would love to hear from the endocrinologist in the group about this insulin drip and hypertriglyceridemia in patients, because I feel like you have strong feelings on this.
Yeah, so this is a recent thing. So even in people who don't have diabetes, you can use an insulin drip to get the triglycerides down, because what insulin does is it increases peripheral LPL, lipoprotein lipase activity, and so that helps clear triglycerides from the circulation. In an individual who has diabetes, this is great. You give the insulin, you can help clear the triglycerides. You can also treat the blood sugars. In someone who does not have diabetes, you can still do it, but you need to have a separate 5% dextrose drip on the side, and usually in the other side. And the dose of insulin is usually about 0.1 to 0.2 units per kilogram per hour, and along with the dextrose drip, as I said, and that's to prevent the hypoglycemia. So the principle is that insulin will increase peripheral LPL activity. LPL is the enzyme which clears triglycerides from the circulation. So that's the thinking behind insulin drip. And it's now actually quite widely used. A lot of folks use it, and the hospitals use it for hypertriglyceridemia induced pancreatitis. I've noticed that in our institution quite a bit. Dan,
do you have a normal saline going around? My hospital uses D5 all the time, and so there you go. You've got your D5, you've got your insulin drip, and you're good to go.
So Dr. Goldberg says she's not a favor of it. I don't really use it, but it's the hospitalists. Hospitalists do use it because it's on one of the leading online educational textbooks. So
I think it's a reasonable thing to try. Some of these patients have no lipoprotein lipase activity at all, and some of them actually have just no LPL expression. And so at worst, you're going to give them the insulin and it's not going to have any effect. And you just have to make sure that you're not causing harm by causing hypoglycemia. There's a direct action of lipoprotein lipase of insulin on lipoprotein lipase, plus also on inhibitors of lipoprotein lipase, like the ANGPTL4 and also an ApoC3. And so, anything you can do to augment triglyceride clearance in this case is a reasonable attempt, with maybe the exception of heparin, the second thing on the list. And, clearly heparin has activity on lipoprotein lipase. It competes for the binding site, heparan sulfate. So lipoprotein lipase is bound in the subendothelium to heparan sulfate. So when you give heparin, you get a transient release of lipoprotein lipase. So conceptually, it makes a lot of sense. Oh, these are patients who are sick. They're in the ICU with acute pancreatitis. They have this, anything that clears the chylomicrons, the triglycerides quicker, should be beneficial. But the real benefit is very transient, and you run the risk of giving somebody with acute pancreatitis, acute hemorrhagic pancreatitis. And so while I think it's sensible to entertain the thought, I don't like it clinically. And I'm not sure there's a set of guidelines that tells us what to do with this, but I think I would discourage it, and I think most people would too.
Controversy about this insulin thing going on, so I think maybe we park there for just a second and talk a little bit more about it. One of our colleagues is saying that it's important to clarify for your hospitalist colleagues to not give glucose orally, which I totally agree, because there's a first pass effect. And like Dr. Goldberg is saying also in our discussion, adding glucose will increase the LDL production. So making those 2 points of clarification. But we have a hospitalist in our group that is listening to us. So yay, number one, thank you for what you do. Hospitalists are amazing. Second, they are saying that they're having really good information or great success with insulin drips, but it is really hard for our nursing colleagues to trust giving insulin to someone who does not have diabetes and being really explicit with how we monitor it. So how do you guys recommend that our hospitalist colleagues write the order for the nurse to monitor? Q2 hours, Q3 hours, how do you guys give that education?
I can tell you what we do in our hospital. Dan, did you want to, you can go first if you want. I'm okay.
So I don't want you to be too jealous, but I haven't had to do any hospital work in many, many years now. So I have no idea what's actually done, but I do get phone calls. I do get called, and my advice to the house staff when they call is only use it when there's hyperglycemia present, and go back to the first thing on this list, which is the most important aspect, which is NPO and IV fluids.
Hydration.
And that's what's going to clear the chylomicrons as fast as needs to be.
Yeah, I agree. Yeah, that pancreatic rest is pancreatic rest is the most crucial thing. So in our again, I'm a consultant. The question comes to us after the primary team has taken care of a lot of things, but typically, so we have an insulin drip protocol, and you need to check the glucoses once every hour so that the insulin drip can be titrated. I will say, most house staff just look online on that unnamed resource and look at the drip rate, and that's how they do it. For this particular situation, I'm not talking diabetes or hyperglycemia, but for hypertriglyceridemia, they just start the drip at, as I said, 0.1 or 0.2 units per kilo per hour, and they run it. It is a very labor intense. Yes. So you on the regular acute care floors, the nursing staff do not appreciate having such intensity, especially now with our labor shortages. So so they do need some kind of I guess, what do you call those? Not acute, but subacute IC. I guess you call them step down units, maybe.
Yeah. We do in the South. I don't know what y'all do in other parts of the country, but somebody else said step down. So there you go.
Yeah.
We call them step down.
Yeah. But I think Dr. Goldberg had something to say. She is not a big fan of the insulin drip, is what it sounds like.
So I think we're all in favor of NPO and IV fluids and team control. And
so then the question you're going to get asked all the time is, when can I eat again? So when do you feed them?
Actually, can I jump in? And actually, before that, we actually get a lot of questions on, we get consulted on these hypertriglyceridemic patients for plasmapheresis. So that is the commonest consult question we get on our endocrine service. And so if we have a couple of minutes, I just wanted to bring that up. So the biggest question is plasmapheresis or plasma exchange something you do for hypertriglyceridemia induced pancreatitis? So, well, there's a lot of case reports out there where people have used plasma exchange or plasmapheresis. It's highly effective in decreasing triglycerides. What does it do? Essentially, what it is it's an extracorporeal therapy where the plasma is removed and it's replaced with some other fluid to maintain the blood volume. So the plasma will be removed, and so with that, the triglyceride-rich lipoproteins are also removed. So it rapidly, within a day or one treatment, the triglyceride levels will come down. However, it is invasive. You need central IV access for this, and it is transient. So you unless you treat the underlying issue and you take care of the eating issues, the triglycerides are gonna bounce up. The best option for hypertriglyceridemia is, as Dan mentioned before, pancreatic rest, not eating. So that is the most, and there was actually a study last year or maybe a couple of years ago in a journal we all read quite widely, Journal of Clinical Apheresis. So it was a group from UT Southwestern, where they looked at plasma pheresis versus just traditional medical therapy. The triglycerides dropped within 1 day in the plasma exchange, but the triglycerides dropped to the same extent in 2 days with just the medical treatment NPO. So it works the same. It's just plasma exchange or apheresis is expensive, and there is risk of line infection, etc. So it is really not recommended. So there are plenty case reports. Yes, there may be a certain situation where you might want to do plasmapheresis, which would be like, someone who's critically ill, like pregnant woman in their, third trimester of pregnancy, or like severe necrotizing pancreatitis and they're critically ill and their triglycerides are sky high and not coming down. That's the only situation I have used it, but I seldom use it. So I would discourage using plasmapheresis. And I'm open to hearing Dan's thoughts on that.
Yeah, I think that's brilliant. I will say that we've used plasma exchange in pregnant women in the last trimester who have a history of recurring pancreatitis and whose triglycerides you really just cannot control with diet alone by the time they get to the third trimester. The inciting event that's triggering it is not going to go away for another 6 weeks, 12 weeks, whatever the number. And the only way to keep them under good control, short of keeping them NPO for that entire trimester, is going to be, even in patients who follow a very low-fat diet, it's really challenging. And we have actually just very recently done plasma exchange on an outpatient to get her through, and she did beautifully. And they keep an eye on the fluid balance. They're very cautious about that, of course. And this was a very conscientious patient who was following a very low-fat diet in that final trimester too. So, but in the inpatients, you're going to get real resolution of the chylomicronemia really by 72 hours, no later than that if they're NPO. And it's just a matter of being patient and getting them through that phase. But you do, of course, want to clear the chylomicronemia as quickly as possible. And people do get a little antsy while waiting. And if they can do one treatment while just to get things going, I'm not opposed to it, but I don't usually push for it.
And one other point I want to make for people listening who take care of these patients inpatient is do trend the triglycerides. You want to, because I see, at least in my institution, the house staff will check one triglyceride level and then that's it. They forget about it. So you want to really trend the triglycerides and make sure they're coming down, trend the lipase levels, make sure it's coming down. So yeah, I just wanted to mention that.
Along the same lines, I just want to add that our patient came in with classic acute pancreatitis and her triglycerides were 4,000, but it's not a rarity for somebody to come in with acute pancreatitis with much lower triglycerides who has been keeping themselves NPO at home for several days and who's already self-treating by using NPO. And by the time they get to the emergency department, their triglycerides, their chylomicronemia may actually already be cleared, and we're only seeing them at the tail end of it. And so sometimes those patients can be missed as a hypertriglyceridemia caused acute pancreatitis because by that time they get there, they don't have the triglycerides in the thousands at that point.
Absolutely. And similarly, the lipase levels may not always be elevated in people who have recurrent pancreatitis. So a lot of these folks may land up in the ER and they get accused of, oh, you've been drinking or you're, pain medication seeking. But these recurrent pancreatitis folks may not have, mount a lipase level like this young girl. So something to keep in mind. I have some patients who I actually have given them letters saying that, saying as such that they have recurrent pancreatitis and that lipase levels may not always be elevated. And it helps actually when they're out somewhere in an emergency room where, they're not familiar with this situation.
Great. So for our patient, we kept our NPO for 72 hours and then resumed the diet. Started off with a clear liquid diet and then progressed to a low-fat diet. I will mention in more mild to moderate cases, there was a recent study a few years ago that looked at timing of refeeding, and actually refeeding within 24 to 48 hours decreased hospital length of stay without any recurrence in clinical pancreatitis. So, for someone that's not as sick as our patient, that is something that could be implemented at the bedside.
Can I actually jump on that point right there? So there's actually a push for that. And I see here you have diet versus TPN, and I hope I'm not stepping on something that you're about to say, but nutrition wise, it's often that we do want to feed the gut as much as is possible. You have better outcomes that way if you're going to use the gut versus TPN. You do also have to be careful with TPN, especially in these cases with lipid provision in TPN. But actually the starting feeds, like oral feeding and those types of things, feeding the gut. I myself have been a huge advocate for testing triglycerides right whenever the patient comes into the ED, just because you do want to figure out, do you want a low fat diet, or are you doing kind of a closer to a regular diet? So I think this is something that you're going to get to further on in the presentation, but that's another thing. So not only when are you going to start feeding the patient, but how, enterally versus TPN, but then also what are they going to be eating? So do you have to do that low fat diet? And I think that it's an important point, and people need to think about what the cause was that brought them in, and then what should we be feeding them whenever they're going to start eating. So.
Absolutely. It's an important point on the medical side of things, but also on the patient side of things. You know, patients get mad just for being NPO for 12 hours, you know, waiting for a procedure. And then, you know, if you tell them a specific diet that they have to eat that's going to stick with them for most of their life, that's a huge lifestyle adjustment that, especially for a 12-year-old girl, would really be a lot to adapt to.
And their parent, who's probably going to have to deal with with feeding the kid as well whenever they get home, right?
Pack the lunches every day.
Yes.
It's so hard.
And as the patient is complaining that they're hungry and they want food, you also have the parent saying, "My kid's hungry, they want food."
Yeah.
So Lauren, you know, before we get to committing this person to a lifetime of very low fat diet, I mean, I think we should talk about the immediacy, the refeeding portion. I imagine you would be in favor of a very low fat diet to start, but we don't know what her triglycerides are going to be a month from now. And so we haven't established what her diagnosis is other than hypertriglyceridemia associated acute pancreatitis. And so it is possible that she doesn't need a lifetime very low fat diet. But I, you know, could you talk about how we should be getting that started, and then what the expectations are in terms of time course over the next week or two, because the acute refeeding is going to be different necessarily than the feeding 2 weeks from now and 4 weeks from now, and how we can monitor that.
Sure, absolutely. So I think the biggest thing is patient-centered care, right? So just as we want to check the triglycerides as they're fasting and see the trend with the triglycerides as they're fasting, I'm a huge fan of checking the triglycerides as we start to feed them again. I'm hesitant to call it refeeding, because refeeding in my dietitian brain means electrolyte abnormalities refeeding. So I'm not going to use that terminology necessarily, but beginning feeds. Beginning feeds. I personally am a huge fan of starting a very low fat diet. So the 10 to 15% calories from fat, making sure that you are meeting essential fatty acid needs, but then also checking their triglycerides as they start to eat, so that you can best serve your patient. They may need to watch their fat a little bit more closely in the interim, in the immediate future, but then as time goes on, as long as their triglycerides don't start to trend up, you may be able to liberalize the fat intake a little bit more.
I think we get into this in just a minute. Let's see.
So we'll move on to the next slide here. Over time, over the next about 3-4 years, her triglyceride trend is shown here. she had 10 different admissions for acute pancreatitis, even despite her triglycerides overall downtrending from the 4,000 level.
So I do want to ask a question that came up a second ago. Is this always seen around her cycle? Like, is there an estrogen component to this? Specifically for her? I mean, I think also with the pregnancy side of it too, but.
Yeah, I don't think I'd be able to answer that question. I'm not sure.
Okay. Dr. Subramanian, is it typically seen at one point in the cycle more so? Is there data on that?
I don't think so.
Okay.
No, I don't think we know. I mean, it makes sense to have, you know, you might get symptoms during the first half of the menstrual cycle, but I don't think we know that for sure.
Okay.
I mean, there's more correlation if they're on oral contraceptives, but
Right.
yeah.
Okay. Sorry, keep going. It was just a good question somebody asked, so I thought I'd throw it out there.
Absolutely. So just to kind of frame our minds now, we have a patient, 12-year-old girl with acute pancreatitis, triglyceride-induced pancreatitis. Now, how do we come up with the diagnosis? What is her etiology for the hypertriglyceridemia? So to start with, you know, we have various different lipoprotein particles, which all carry cholesterol and triglycerides in varying amounts. And on most of the particles, they carry an ApoB lipoprotein, compared to the HDL particle that carries an ApoA1 lipoprotein. And shown here again is kind of a different partitioning of cholesterol and triglycerides on each of these particles. Now, in patients that have triglycerides that are less than 1,000, we can broadly categorize these patients as either having a multifactorial or polygenic hypertriglyceridemia, a combined hyperlipoproteinemia, or a more rare cause of dis-beta lipoproteinemia. Compared to patients with triglycerides over 1,000, those patients are considered to have mainly one of three conditions: a multifactorial chylomicronemia, a monogenic chylomicronemia, or a lipodystrophy. Overall, hypertriglyceridemia has been shown to be 99.9% polygenic and environmentally influenced. And again, most of the patients that we see in the adult world, I can at least speak for, are usually occurs with multiple factors. Many of them have diabetes, insulin resistance, metabolic syndrome, which on top of a polygenic factor leads to one of these syndromes. And then as a note or an aside, patients always ask, and clinicians as well always ask, should we do the lipid panel fasting or not fasting? And it really depends on what you're looking for in that lipid panel. If you're just looking for an LDL cholesterol or an ApoB level to reduce someone's atherosclerotic risk, a fasting lipid panel is not required. A non-fasting is okay. But if you're really looking for a triglyceride, as well, if you're looking at the triglycerides as well as the other lipoproteins on your lipid panel, then a fasting lipid panel is recommended. And the postprandial triglycerides are rarely over 400. So even if someone eats breakfast and you're checking their lipid panel at lunchtime, usually their triglycerides are still less than 400, even if it's a non-fasting lipid panel.
Can I add some basic, so before you move on to the next slide, Chad. So just for the folks who are very naive to the lipoprotein world, chylomicrons are the really large particles that are generated in the gut and carry triglycerides. That's the particle way to the right of your screen. And when you have triglycerides over 1,000, as Chad has up there, you have chylomicronemia. So that's the terminology. So chylomicrons in the blood, chylomicronemia. And when they come in with the symptoms like this young girl had, that is chylomicronemia syndrome. So this young girl came in with chylomicronemia syndrome with the features of pancreatitis, etc. So just some basic, simple, basic terminology. I think you can move on.
So next, to work up her hypertriglyceridemia, we've now considered her to have a chylomicronemia syndrome. And the next step in working up her underlying etiology for the chylomicronemia is to do genetic testing. For this patient, for I'd say most patients, this occurs on an outpatient basis, usually in the lipid clinic. And there's five main genes that are attributed to a chylomicronemia syndrome, and that can be deficiency or mutation in the lipoprotein lipase and lipase maturation factor 1, GPIHBP1, ApoC2, and ApoA5. And for our particular patient, her genetic panel for chylomicronemia was negative across the board. So this led us to giving her the label of a genotype negative familial chylomicronemia syndrome.
Oh, where's a good, or any recommendations for where to get this testing done?
I think we use Ambry Genetics at our hospital. I'm not sure if there's other. I'm sure there's other labs. I would reach out to a lipid expert in the area to see if testing is available, for your patient.
It's a pretty standard panel, and all of the major genetic testing companies will do the standard chylomicronemia panel.
Enzymatic activity, did you guys do those?
Pardon me?
LPL enzymatic activity test?
No. So that's for research purposes only. There's I'm actually just reviewing a paper for JCL, someone had submitted regarding some assays for LPL activity. It's extremely complicated testing to do, and it's not commercially available for LPL activity. It would be great if we had a good LPL activity panel that we could just order on patients. I think that would be incredibly useful for sorting out differences between, especially between chylomicronemia syndromes, but to see them changing as they improve with diet and other strategies.
Dr. Cheeley, do you think going over this figure really briefly might help?
Oh yeah, go for it.
Do you think that might, just for the folks who are unfamiliar with the different genes, and we'll keep it simple and quick. But to Chad's point, they went down this monogenic pathway because this is a young woman, a young girl with no history and no other risk factors. So this is going down the monogenic or FCS, familial chylomicronemia syndrome. That's why they tested this. So if you look to the right of your slide, LPL is made inside, let's say this is the muscle cell myocyte, for LPL to be made, you need LMF1, that's lipase maturation factor. So if you have a genetic defect in LPL, you don't make LPL. If you have a genetic defect in LMF, which is needed for the LPL to mature as it's made inside the cell, you don't make LPL. Once the LPL is made, it's secreted into this interstitial space that's between the cells and the endothelium that's on top there, and it gets anchored onto that the heparin sulfate. And then there's this protein GPI-HBP1, which actually grabs the LPL and takes it to the other side of the endothelium. And so if you have a defect in the GPI-HBP1, you can't grab the LPL, and the LPL will just sit there and it'll just get degraded. So a mutation in GPI-HBP1 will again cause, similar to all the other very high triglyceride levels, just like LPL deficiency, which is the most common reason. And then for the ApoC2 is a cofactor that's necessary for the LPL to work. So if you have a mutation in ApoC2, it will not work. LPL will not work, so you'll have marked hypertriglyceridemia. And similarly, ApoA5 also seems to help this whole process of LPL hydrolysis with ApoC2. So defects in any of these genes will cause very high triglyceride levels.
Super helpful.
So Dr. Stauffer, if this LPL activity assay was commercially available, in the case of deficiency of LPL, LMF1, or GPI-HBP1, I presume that the enzymatic assay would be very low. But in the case of ApoC2 or ApoA5, the enzymatic assay would be normal. Is that something that is known in terms of how this assay works, or it's not there yet? That's more of like an idealistic way of developing an assay.
The way I think of it is really in distinguishing FCS from MCS, in that the MCS patients, they have transient reduction in LPL activity, especially suppressed in times of severe insulin resistance and severe hyperglycemia. And as that condition recovers, LPL activity starts to recover as the triglyceride levels go down. And so I think it becomes more measurable in that circumstance. But your point about what is the LPL activity when somebody has monogenic FCS caused by severe ApoA5 mutations, I would guess the LPL activity in vitro is probably fine, but in vivo is probably pretty lousy. And I think distinguishing between that might be, I don't know how the laboratory scientists would be able to do that.
Okay.
Diet and how to treat this, but we are getting a couple questions about ApoC3. Can we commercially check that? Do we test for that commercially?
Not that I'm aware of.
Yeah,
Okay.
I think only research. You can probably do it at the bench, but
Got it.
yeah.
Let's get to how to treat this girl.
So first, number 1 through 5 is always for her diet. It's all about diet control and trying to lower her intake of fat to try to limit triglyceride production. So for her, 1 cup of fruit, 1 serving of fruit per day, I should say.
Sorry, Chad, I just want to
recommended.
interrupt for a second because I think you misspoke there, and I want to really make that clear for all the listeners. So low-fat diet is not about reducing triglycerides. It's about reducing chylomicrons, the particles that carry the triglycerides from the intestine. Because of course, triglycerides production is enhanced in the liver by other types of diets. But for chylomicrons, it's fat.
Right. Thank you for that.
They just misspoke.
Yeah. So for her, recommended diet would be 1 serving of fruit, veggies, whites, legumes, seafood, and lean poultry. Because of her low-fat diet, she would have to supplement fat-soluble vitamins, vitamin A, D, E, and K, and also supplement essential fatty acids, 2 to 4% of her total caloric intake, with alpha-linoleic acid and linoleic acid. Her fat intake should be limited to less than 10 to 15% of her her daily caloric intake. And to supplement her caloric intake, she can use MCT oil. And overall, she'll have to avoid refined carbs, foods and drinks with added sugar. And in the case of someone who does drink alcohol, it's recommended to completely eliminate alcohol. At this point, because we were really desperate to try to lower her triglycerides, we used all the tools possible for us at this time, which was fenofibrate, 160 milligrams daily, as well as icosapentaethyl, 2 grams twice a day.
Can I jump in and have a comment about the diet? One thing that I want to point out in this is the fact that it is a low fat diet. Saturated fat, trans fat, unsaturated fat, doesn't matter. It's a low fat diet. So your typical heart healthy diet does not apply here. So we're not just talking about doing lean proteins, and you can use olive oil and all of that. The low fat diet does include the unsaturated fats. And then MCT oil is a prescription grade oil. So this isn't the MCT oil that you can just buy off of the shelf at your local health food store, or off of Amazon is where most people get it these days, let's be honest. But rather it's C8, C10. It doesn't include the C12, the lauric acid there. So because of the fact that that's not necessarily always broken down as a medium chain triglyceride. So there was somebody in the comments though, or the questions that asked about carbohydrates. And typically those are also you try to keep them to less than 60% of daily calories, as much as is possible, because you only have carbs, fat, and protein. So you got to do what you got to do, but you try to limit simple carbohydrates and try to limit the overall carbohydrate intake during the day. So they can't just pick out on candy. And as a middle schooler, right? If you say low fat, they're like Skittles, yes. So
Gummy worms are fat free.
They are, and so are marshmallows. On the package, it says a low fat food.
Lauren, how is the MCT oil taste? Is that real delicious?
I mean, I don't shoot it back on a daily basis. And it's also a very, very teeny amount. A lot of the patients that I've worked with, they're using it like as part of a salad dressing or something like that. It's a very small amount, because if you try and overload the system too quickly with MCT oil, you get very unpleasant GI effects. Which again, as a middle schooler, you don't want to have diarrhea. Nobody likes to say that word, but if you do too much,
it is
too much
of
the
term.
MCT, it is. And sorry that that's going to be on the recording. But that's one of the things that can happen. So it's not super delicious, but it is a prescription grade. It's also very, very expensive, and it can oxidize really quickly too, so it can go bad really quickly. And so there are some out there that are emulsified to where the mouth feels a little bit better if you're mixing it into liquids. And then there's also MCT powders out there now.
Savitha, would you have used the fenofibrate and high dose omega-3s?
If we're thinking monogenic chylomicronemia, no, because these drugs do not work in these folks. I mean, yeah, she has, she's tested negative for the classic 5 genes we would test, but I don't think fenofibrate will be effective in this woman. I am of the teaching, what I learned from my mentors is that fish oil is not used and doesn't work effectively in people who have marked hypertriglyceridemia, like this young girl, 4,000 triglycerides. Also, you have to take 4 capsules. They're big capsules, and 12-year-old, I don't know that I would have done that, but I understand why it was done, because you don't know what's going on, and you are grasping at straws, so you do what you can. So but no, to be honest, I don't think either one of these will work in this young girl.
I have a follow-up for Mary Katherine also. So in MCS, who are patients that actually have some LPL activity, as long as they don't have chylomicronemia and their LPL is not saturated. If their triglycerides are in the thousands and LPL is completely saturated, should we expect any benefit at all from fenofibrate or high-dose omega-3s in that context?
If it's completely saturated, I don't know I don't have a study to quote for that, but I think we're thinking along the same lines. If that's the way that it's working and it's completely saturated, then I wouldn't think. But then also, are there different times during the day when it may not be saturated, and then the drug can have some activity at that point? So I think you might see some, but definitely not the 40% or the 50% that you're used to seeing. But you may get something from it, because it may not be 100% saturated 100% of the day. And if the half-life of the drug is 24 hours, then we have that coverage during those times.
So maybe in this case, where we don't even know really what's causing her disorder, it's reasonable to try some medicine. But I agree with you, Savitha, that it's my expectation of benefit is pretty low.
Yeah, and I think that's seen in the graph that Chad showed us too.
Yeah.
Which I'm excited to see again. Can we go back to that, or can we keep going? We are over an hour, so I want to make sure that we get to the punchline too, Chad.
Of course. So this was the graphic of her triglyceride trend. Now, after implementing strict low-fat diet, the fenofibrate and icosapent ethyl, again, out of desperation, we initiated alirocumab because she continued to have hospital admissions despite a strict low-fat diet. And she was very reliable. Her parents were very reliable. And unfortunately, with the alirocumab, it pretty much had no benefit in lowering her triglycerides.
Yeah, we got a question a second ago, and I think it's where you're headed, about compassionate use. So if we can spend like 60 seconds talking about possibly, what's there, and literally 60 seconds, compassionate use for different patients, that was something that someone wanted to discuss.
Yeah, so the next step, after we were grasping at straws and there were no straws left, we applied for compassionate use for volanesorsen, which was in trials at that time, and evinacumab. So volanesorsen is an ApoC3 antisense oligonucleotide, and it ApoC3 in its native form inhibits lipoprotein lipase. So volanesorsen basically inactivates ApoC3, which then allows the lipoprotein lipase to work uninhibited. In evinacumab, similar principle, except instead of targeting ApoC3, it's an antisense oligonucleotide targeting ANGPTL3. And unfortunately, because she was a pediatric patient and she was genotype negative, we were denied compassionate use by the CMOs of both of these companies, and we weren't able to use them.
Earlier was also about a pregnant patient and compassionate use. I think that would also be kind of a hard sell because they're a protected class. But you could certainly make your case on that. They just don't like to test things in pregnant ladies.
We've also learned since this patient presented from a presentation by Bob Rosenson at I think it was ACC last year, that in FCS patients, evinacumab, which is the ANGPTL3 ASO, has no activity.
That's not work.
Sorry, it's a monoclonal antibody. It's not an ASO. It's an anti-PD-L3 monoclonal
Yes.
antibody.
Yes.
But has no activity in FCS, but may have and ought to have some activity in MCS, and that was seen.
All right. So the next phase of this was when she now turned 15 years old. She again presented for triglyceride-induced pancreatitis. Again, her lipase level was north of 5,000, and her triglycerides at that time were 2,370. The interesting thing and kind of the turn of events was that on her urine analysis, she was noted to have a protein level of greater than 500 with a normal creatinine. And this then prompted a protein creatinine ratio to be drawn, and that was 3,000. So this led us to then test for rheumatologic disease with her nephrotic range proteinuria. Her ANA titer was extremely high, 1 to 2,560. Her double-stranded DNA was elevated and her chromatin level was elevated. So we then pursued renal biopsy, and she was diagnosed with membranous lupus nephritis. So is there an overlap between her hypertriglyceridemia syndrome and her membranous lupus nephritis? So there was some work done by Dr. Stephen Young at UCLA, and he looked at 33 patients with genotype negative familial chylomicronemia and tested them for autoantibodies to GPI-HBP1. And one of those 33 patients tested positive for these autoantibodies. And we just happened to be doing a deep literature search for this patient because it was very frustrating as clinicians and of course as the patient to continue to have admissions for pancreatitis without any great therapeutic intervention to lower the triglycerides. So then when we saw this paper by Dr. Young, we contacted him and asked him if he'd be willing to run the blood sample for our patient, and hers became strongly positive for autoantibody to GPI-HBP1, which is this protein that sits in the interstitial space and helps move or traffic the lipoprotein lipase from the interstitial space to the capillary lumen. So from here, we diagnosed her with this autoantibody-induced chylomicronemia. Our rheumatology colleagues were able to provide great assistance in initiating immunosuppression with mycophenolate and hydroxychloroquine and pulse dose steroids. And rituximab was also used given how severe and advanced this patient's condition was. She got 2 doses, 2 weeks apart, followed by every 6-month infusions. And since the initiation of the rituximab and the other immunosuppression medications, she has had no episodes of pancreatitis.
That's awesome.
So looking at her trend now, we started off in January of 2019 with a triglyceride of 4,000, despite intense diet control, fenofibrate, icosapentaethyl, and alirocumab. She continued to have admissions for acute pancreatitis. And upon diagnosis of her autoantibody GPI-HBP1 and the initiation of immunosuppression, we were finally able to bring down her triglyceride level over the course of a year from about 2,000 down to 138 just last week. So since then, we've been able to liberalize and now normalize her diet, since we are effectively treating the underlying mechanism for her triglyceridemia and chylomicronemia. And she's continued on her immunosuppression by rheumatology, and her fenofibrate has since been discontinued now that we've seen her triglycerides come down to 138.
Hey, thank you for sharing with it. Do our panelists have any last things that they want to bring up? Or I know that Dr. Subramanian is probably twitching at this prednisone 7.5, but we don't have time to get into it tonight. We can have that discussion another time in a 15-year-old kid. Any last thoughts from our panelists? This was so great.
Yeah, I just want to say that, that was a great presentation, Chad. Thank you for bringing that case to us. So, we really wanted to talk about chylomicronemia, which is a very uncommon phenomena, and familial chylomicronemia, which is a rare disease. And this is not really FCS or MCS. This is a unique sort of subset of MCS that behaves like FCS. I think that's the way to think of it. So this is a rare presentation for a rare condition. And the take-home message is not to know about autoimmune anti-GPI HBP1, but to think about chylomicronemia and how we manage it in the acute setting, and then transition them to the outpatient setting. And typically, right now, our only therapy is very low-fat diet in that context of no lipoprotein lipase activity patients, until we have therapeutics like olezarsen, which is in clinical trials to manage this. So thanks, everyone, and thanks for Lauren for adding on at the end and joining us as a late panelist. When we realized that we didn't have a pediatric dietitian who could come in and really speak to the condition well. So
thanks for having me, and you did a great job on the case. This is a super interesting case, so thanks for presenting it to us.
Thank you guys so much for joining us.